So we'll move on to the cancer stomach. Okay, the site most common site again in India, it is the antrum. So what are the various parts of stomach?
Gastric antrum.
What is this?
Fundus.
What is this? And
Fundus.
what is one?
Antrum.
One is fundus.
Fundus.
What is two?
Cardia.
What is three?
Pylorus.
Four?
No, 4 is pylorus.
Four
is pylorus. 3 is antrum.
3 is antrum.
Okay. So the most common site is the antrum. Okay, this is the most common site in India, in the world. So no need to remember this, but just remember in India it is antrum. And the most common type is, here it is adenocarcinoma. In esophagus it is
Adenocarcinoma.
esophagus.
Developing countries, squamous cell carcinoma.
Yeah, esophagus is squamous cell carcinoma. In stomach it is adenocarcinoma. So
in India is
sorry.
In
They
India
show
is
the
adenocarcinoma. Yeah, previous like this. But sir, in India, incisura it's also written.
No. Antrum near the incisura. Antrum near the incisura. That is what I meant. In the they'll give antrum only. Don't worry.
Okay, sir.
Okay. So what are the causes? 6 S are the causes. Smoking, spirit is alcohol, spicy food, salted food, smoked food, stored food. These are all the causes for gastric cancer. So where this food will be taken more? Spicy, salted, smoked. Where is this? In which part of the world they are more?
Western.
Okay,
Indian
not
as
Western
well.
also.
Indian as well.
India.
No, this salted, spicy, and smoked food.
Chinese.
Chinese. Japanese. Okay.
Japanese. So they have the highest incidence. Out of 100, around 40% of them have gastric cancer in Japan. Okay, but because they have the higher healthcare facilities, in the initial stages only, it will be picked up. Okay, in the very initial stage, small tumors only they will be picked up, and they even do endoscopic resections. They won't go for this higher surgeries and all. Okay, and these are the 4 A's, 6 S are the etiology. These 4 A's are the predisposing factors: adenomatous polyp, atrophic gastritis, blood group A blood group people are more prone. Why we don't know, but they are more prone. Anemia, pernicious anemia. Okay, so any of you are having A blood group? Yes, no?
Yes, sir.
But don't worry. Okay, just these are studies. Just based on studies, they will give just that it is more common in them. That's all.
Got
So
it,
maintenance disease, genetic syndromes. These are all the causes of gastric cancer. What is this? CAGA. It is secreted by
H. pylori.
Yeah. So clinical features. What are the various clinical features? We can remember it as stomach only. S is for silent. Most of the times it is silent, no symptoms. T is tumor. Sometimes the abdomen, they will have a mass felt. O is outlet obstruction, gastric outlet obstruction. He will have vomiting. He will have this one. Those findings like gastric outlet obstruction. M is malaise, weakness. A is anemia. The patient will have anemia because of blood loss. C is cachexia, weight loss. H is hematemesis. Okay, these are the various symptoms of clinical features of gastric cancer.
Gastric carcinoma.
Okay. Yeah, this is understandable. So that's I'm little I'm going fast in these slides. Okay,
Yes,
there's
yes.
nothing much to
Yeah.
explain here.
Self-explanatory,
Okay.
sir.
Yeah,
It's
it is
fine.
self-explanatory. Whatever is there, it is just a silent tumor, and they will not be asked also. And this is a little important. Krukenberg tumor. In premenopausal only, in females who are premenopausal, what happens is they will have the ovarian tumor. This is known as Krukenberg tumor. Gastric cancer will spread through transcoelomic route. Okay, through the peritoneum it will spread, and the ovaries will be the ovaries will be enlarged. This is known as Krukenberg tumor. Okay, it is seen only in premenopausal. It is not seen postmenopausal because the ovaries are atrophic in postmenopausal. Only premenopausal it is seen. And Sister Mary Joseph nodule. Have you heard it before?
Yes, sir.
Yeah, around the umbilicus. So this is Sister Mary Joseph nodule is nodules around the umbilicus. It is identified by one Sister Mary Joseph. Okay, she was the first one to identify. So many patients with gastric cancer had nodules around the stomach. Okay, so she was the one who identified it. And Blummer shelf is in the pouch of Douglas. There will be deposits. Vircose node is the left supraclavicular lymph node. Okay, and Irish node is the left axillary lymph node. These are all. What are these all? If these are present, what does it indicate?
Gastric carcinoma.
Gastric carcinoma, yes, but it has already
Metastasis.
it has metastasized. Yeah, if any of them are present, if out of these 5 any of them is present, that is the cancer is inoperable. Okay, these are all metastatic signs of metastasis. Okay, so other inoperability is if the patient is having ascites, if the patient is having liver mets, if the patient is having peritoneal mets, if the patient is having pancreas infiltration, or any of the named previous 5 like Krukenberg's tumor, Vircose node, Irish node, and Blumberg shelf. Okay, if anything is there, then it is also inoperable cancer. Okay. Yes, no?
Fine, sir.
Okay, stagings and all we can skip. So what is early gastric cancer? If the mucosa and submucosa only is involved, if the mucosa and submucosa, there are 4 layers, right? Mucosa, submucosa, muscle layer, and subserosa, serosa layer. If mucosa and submucosa only is involved, then it is
Esophagus.
early gastric cancer,
Oh, sorry.
with or without lymph nodes. Okay, so here you can do for T and N staging, you can do an endoscopic ultrasound. You can also take an endoscopic biopsy. Okay, for metastatic workup, you need to do a CECT abdomen, same like gastric cancer, but same like esophageal cancer. For metastatic workup, what you do for M in esophageal cancer? For T, what you'll do? For N, what you'll do? For M, what you'll do?
Metastatic CT.
Endoscopic.
For metastatic, you will do an contrast CT. Yeah.
Okay. Better answer. Any better
Endoscopy
answer?
ultrasound.
Esophageal cancer.
PET CT.
Yeah, it is PET CT. Overall staging is CECT abdomen. Here also T and N endoscopic ultrasound. METS CECT abdomen. This marker, remember CA 72 for 4. This is not asked in our exam, but just remember CA 72 4. Okay. Okay. To diagnose the peritoneal METS. Peritoneal METS is a sign of
Gastric carcinoma.
yeah, gastric cancer, but what is that? It is a sign of inoperability. You can't operate.
Okay.
Okay. What is the best investigation? To identify peritoneal METS, what is the best investigation? Peritoneum is very small nodules on the peritoneum. We can't pick it up with any investigation. We have to do a
Laparotomy.
special test. What is that? Like not it is special test means it is a special somebody is telling. What is that?
Laparotomy.
Yeah, laparoscopy. No need to do a laparotomy. Just put a scope inside, laparoscopy, and then if there are peritoneal mets, you will abandon. It is a sign of inoperability. Where else yesterday or day before yesterday I was telling, laparoscopy is investigation of choice for
Kidney related emergencies.
No, in testis, in one topic I was telling laparoscopy.
Distant testis.
Sorry?
Distant testis.
Undescended testis. Yeah.
Yeah.
Undescended testis,
Island.
intra-abdominal. The best investigation to pick it up is laparoscopy. Okay, same here. Okay, this classification is. See, suppose the cancer is here, the cancer is here, or the cancer is here. Okay. Do we need to do a total gastrectomy like we did in esophagus? Total esophagectomy, is it necessary? Not necessary?
Partially you
necessary.
can
Yeah,
remove
partial
it.
is enough. Okay, partial is enough. So for that, always 5 centimeters margin we have to see. 5 centimeters here, 5 centimeters proximal margin should be cleared. 5 centimeters proximal margin should be cleared. And distal margin is always D1. Okay, because you have to remove the antrum part and pylorus part, because again it may recur there. So even if it is here, you will do a total gastrectomy. If it is here, partial gastrectomy. Here also partial distal gastrectomy. Got my point? Proximal margin is 5 centimeters. Distal margin is D1. Yes? Understood?
Understood, sir.
Yeah, proximal margin is 5 centimeters. Distal
Please
margin is
explain
D1.
again.
Yeah.
So is it all right if you could remove that pop-up?
Yeah, I'll remove.
Thank you, sir.
See, if the cancer is here, I am telling there is a proximal margin and distal margin. We have to remove it, right? The proximal margin is 5 centimeters from the tumor. Within 5 centimeters, whatever is there, we have to remove it. And the distal margin is D1, duodenum 1. The first part of duodenum should go. We cannot remove the second part of duodenum. Why?
Because we have the ducts opening there.
Yeah, all the ducts are opening here only. So we can remove up to the D1. Okay, 5 centimeters proximally, distally up to D1. Why we have to include D1 is there is high chance that the patient will develop antrum and pylorus. These are the two parts where malignancies may develop again. So we have to remove that in toto. 5 centimeters proximal and up to D1 distal. Okay.
Okay.
So if the tumor is proximally lying, we do 5 centimeter above total resection.
Yeah,
Then
if
it
suppose the tumor is here, that's what you did, right? If the tumor is above here, right?
Yeah.
Then we have to remove the esophagus also. 5 centimeters esophagus we have to. This rule applies everywhere.
5 centimeter only above or 5 centimeter below top?
5 centimeters above up to D1. This requires a total
Up to D1.
gastrectomy.
Oh,
Okay?
okay, sir.
Yeah. And this is a reconstruction which we are not doing it nowadays just for historical purpose. Billroths nobody is doing nowadays. Okay? This is just we'll do a simple gastrojejunectomy. So this is how it will look. For see, this is the stomach. This is the normal stomach, usual stomach, but we have removed this part here. This part. So we have joined the stomach to the jejunum, and the bile will be coming from here. Okay. Why is it coming? Is this image clear?
Yes, sir.
This is gastrojejunectomy. Okay. Distal gastrectomy plus gastrojejunectomy. They removed this part of stomach in between. Here stomach is there, right? They removed this part of stomach and they have anastomos to the jejunum. So food will go like this. This bile salts, bile ducts and all will go like this. Okay. Clear?
Yes, sir.
Okay. So this is after subgastrectomy. This is Billroth 2. Billroth 1. Nobody is doing nowadays. Billroth 1 is obsolete. Only Billroth 2, that is distal gastrectomy with gastrojejunectomy. Okay. This Billroth 1 is not being done. Okay. So this is the Billroth 2. This is the jejunum. Jejunum is anastomose to the stomach. Suppose if the patient is having peritoneal mets, having liver mets, having Krukenberg tumor, what does this mean?
Inoperable.
Inoperable. Okay. So in inoperable cases, what you will do? You will do something or you will leave the patient?
No palliative care.
Yeah, we have to do something, right? We have to do some palliative procedure. Like simple gastrogenostomy or a simple gastrectomy. If the patient is bleeding a lot, we have to do a gastrectomy. Or what is SEMS?
Single endoscopy.
Morning I told you.
Self-expanding metal stent.
Yeah, self-expanding metal stent. So you just put it so that the patient will have some appetite. He can take some food for his nutrition. Okay, otherwise he will be emaciated. And now there are two variants. Till now we talked about adenocarcinoma. Adenocarcinoma only we talked about. So there are two variants for gastric carcinoma. One is
Hodgkin's lymphoma.
Yeah, non-Hodgkin's lymphoma. That is also a little common in stomach, and other
Gastrointestinal.
Gastrointestinal
Stromal
tumor. These two are also little variants of gastric cancer. So I put it in a tabular format so that we will easily remember. This is more important for NEET, and they may ask you because in our exam also. So just see, non-Hodgkin's lymphoma, the most common site is stomach. GIST, the most common site is stomach. Lymphoma, it can occur anywhere, right? In the lymph nodes, anywhere. But non-Hodgkin's lymphoma, the most common site is stomach, in stomach lymph nodes. And most common location in stomach is antrum. Okay, antrum. Except for Burkitt's lymphoma, it is fundus. Others, it is antrum. Here, it can occur in the proximal stomach, gastric curve, or the fundus. Anywhere it can occur. Okay, there are many varieties, and here see, origin is lymphatic tissue origin. Obvious, right? Lymphoma, it originates in the lymphatic tissue. Here, gastrointestinal stromal tumor in the interstitial cells of Kajal. Heard about it? Interstitial cells of Kajal? Yes, no? Anatomy or physiology? Heard about it? Not heard?
Heard of it, sir. Heard of it.
Yeah, these are pacemakers actually. Pacemakers in the intestine, in the bowel, which will cause peristalsis. So this tumor arises from these cells, interstitial cells of Kajal. Okay. So Dawson criteria, Lugano staging. Just if anybody wants to remember. Otherwise, no need. And treatment is maltoma is there. What is the treatment for maltoma? Just leave this. What is the treatment for maltoma?
Triple therapy.
Sorry.
Triple therapy.
Maltoma. What is the cause of maltoma?
H. pylori.
H. pylori.
100%.
So H. pylori treatment. Give H. pylori treatment and give chemotherapy. R-CHOP regimen. Chemotherapy you give. Okay. No need of surgery for non-Hodgkin's lymphoma. They will tell, right? If lymphoma, you give chemotherapy, it melts like ice. Okay. It will be such curable disease. So if you just identify a lymphoma, you just give chemotherapy, it will be gone. If maltoma is there, give H. pylori treatment. Whereas in GIST, you have to do surgical resection. There is no need of doing lymph node dissection, but you have to do surgical resection. You do a endoscopic biopsy is the investigation of choice. And CD117 positive. What is CD?
Cluster differentiation.
Very good. So CD is cluster of differentiation. CD117 positive. So they'll give you a patient with symptoms of gastric cancer. He was identified to be CD117 positive. Okay. So it is non-Hodgkin's lymphoma, adenocarcinoma, gastrointestinal stromal tumor. Okay. So this, if you see CD117, you have to answer it as gastrointestinal stromal tumor. And one more point in this is the patients you will give along with surgery, you will give imatinib. This is a drug. Remember, imatinib. This is the drug which will give for gastrointestinal stromal tumor, imatinib. Okay. Yes, all right.
So it says CD34 wild. Does that mean it's an aggressive form, like much worse than?
Much worse than?
No. I don't know how to frame the question, but there are two CDs, right? CD117 and CD34.
34, yeah.
But besides CD34, it says wild. So is there any significance?
Yeah,
That something
actually,
that we have to
if you go in
remember?
depth for GIST, there are two types of varieties. One is the wild variety and one is the common variety.
Okay, yeah, that's what I was asking. The wild variety, is it very aggressive
Yeah,
compared
it is
to?
more aggressive than the common variety, but luckily it is little rare. Okay, and this imatinib doesn't work in the wild variety.
Okay, sir. But it's enough if we remember CD117, right?
CD117,
For GIST.
CD117 positive it is. CD117 positive. Yeah, that you remember, it's enough.
Okay,
CD117 negative and CD34 negative is, that is different. That is for wild variety of GIST.
Okay, sir.
Okay, yeah.